Welcome to the NeoFOCUS-UK Education Group webinar series.
Good afternoon, guys, and thank you very much for joining us at this NeoFOCUS webinar. It gives me great pleasure to introduce Professor Heike Rabe, who is a Professor of Perinatal Medicine from Brighton, Sussex Medical School in the UK. And extra thanks for Heike for joining us today because she's currently away in Toronto at the moment. Professor Heike Rabe has been instrumental in the research and the development of delayed cord clamping. This WHO recommended intervention is now widespread throughout the world and has been shown to make sort of such a big a difference to not only term babies, those are the smallest babies that we help deal with. And amongst this, she's been involved in hemodynamic research since the start of her career, most notably as part of the neocirculation trial, which I was lucky to be a part of with her, looking into sort of the hemodynamic monitoring, non-invasive diagnostic techniques, and also looking at neonatal formulations of medications. And there's so much that I could carry on talking about with her research career, but I'm going to pass the floor over to Heike now to present her work looking into the hemodynamics of delayed cord clamping. And if you guys have any questions, please put it in the Q&A, and we've got Aaron and Virginia who are both here who will moderate the session and the questions afterwards. But once again, thank you, Heike, very much for giving us your time and presenting about delayed cord clamping.
Thank you very much for your kind introduction. First of all, I need to share my screen, which we tried earlier. Can you see the slides?
We can see them fine, Heike. Yep.
Okay, excellent. Okay. So thank you very much. I'm very happy that this NeoFOCUS group exists, because I believe that circulation is an important part of what we do for our babies and what we have to observe. And now the slides are not moving. Yeah, okay, I have to do it like that. So first of all, just remind everybody, keep calm and first do no harm. So that's a very important quote to think about when we think about what we now call optimal cord management. So the word people still use quite often delayed cord clamping or deferred cord clamping, but we are thinking of it as part of the sort of pathway from transition to intra to extrauterine life. It's important if you do optimal cord management to look at the safety profile, how to implement it, and you can only do that in consultation with the stakeholders who are also involved, and also think about ethical consideration, as we always do, especially when we also counsel the parents who might get a preterm baby. So, okay. So just a reminder, what are the main problems of premature infants? We do need to have them very well adapted after birth. So this is age 33 in the first 3 days of life. And as you can see, the blood pressure generally goes up if the baby adapts very well. And there's different measures for the different gestations. So if you're in the lower gestation, we do not have that much data, but it does also go up if you treat them well and if you provide them with the extra blood. We still have intraventricular hemorrhage as one of our major threats, especially as we are now treating babies below 24 weeks gestation, where there is a high risk. We have two different methods of ventilatory support. And another problem which quite often goes up later in life, that babies need red cell blood transfusions. And here you can see a publication we did like more than 20 years ago, where you, at least at 32 weeks and below, you have at least a 50% chance, which goes to 100% to the lower gestation of needing at least one blood transfusion. That is also quite often a concern to parents. Blood transfusion can also have negative side effects, fluid overload and so forth. So if you can avoid that, especially in the first days of life, it will certainly stabilize the overall circulation. So just to manage, so what we call optimal cord management, there are different methods on providing it. So the most common one is delayed or deferred cord clamping, leaving the cord intact for at least 60 seconds in preterm infants and up to 3 to 5 minutes in term infants before clamping and cutting, and that enables blood from the placenta to go into the baby. Further development is that you start resuscitation or stabilization with an intact cord, and starting resuscitation for those who need it, and I will talk about this later, before the cord is clamped and cut. And then alternative methods were cord milking and cut cord milking, which I'm not focusing on today. So if you look at the methods, how were these methods studied? Most studies were time-based, and not volume or otherwise based. So that's what people sort of were coming up with. And initial comparisons were to compare immediate cord clamping, which is usually less than 20 seconds, versus delayed cord umbilical cord clamping. The milking mechanical transfer is a sort of versus immediate cord clamping has been compared, and then the physiological umbilical cord management. They're quite enough. So interest has increased in these kind of studies, and we now can, as you probably know, that when we did the meta-analysis of the studies available, we found that for preterm babies, there's a reduction in hospital deaths by 27 to 30% if you provide delayed cord clamping of at least 1 minute for the babies. In line with that, very few studies could provide information about higher circulating blood volume for the first 24 to 48 hours. Obviously, after that, it's quite difficult because we also take a lot of blood to the laboratory. So one thing which I'm always pledging for is not to reduce the number of blood samples you are doing in a baby, and really think about what do you do with the results. It's really necessary, and that also applies to when the babies are older. Always think about what is your question you're answering. Lots of studies have looked into blood transfusions, the need for it, and found that there are fewer blood transfusions needed. But most importantly, that was better systemic blood pressure, and in line with that, a reduced need for inotropic support, which in itself can be a risk factor for intraventricular hemorrhage and other injuries. Some studies have looked at the superior vena cava flow, which is also a measure on how well the blood circulates, what the blood volume is about. And others looked at left ventricular output, which was also reduced. There are some earlier studies looked into necrotizing enterocolitis, oxygenous cerebral measurements, but overall, what is really important so far, there have been no adverse effect seen when you look at neurodevelopmental outcome at 2 years of age, and we're just doing another meta-analysis on this question. So if you think about the fetal blood transfusion, obviously runs between the placenta and the baby, and during most of the first and second trimester, about 50% of the blood is in the placenta, because that has to do all the work, and 50% is in the baby. And as nature is sort of supporting the baby in the last trimester, that shifts so that more blood is actually inside the baby. So if you then do immediate cord clamping, especially in the preterm infants, there's lots of blood which is left inside the placenta, and then the baby cannot fill up their organs, especially in the lungs, and I will talk to you about that in a minute. And that reduces very much the chance of having a good adaptation after birth, especially if the baby is otherwise distressed for other things. Another important thing which I would like to remind you is that the cord blood also has a lot of stem cells. And these stem cells can be very beneficial for the baby to repair any damage which might have occurred before the baby was born. We know from animal studies that the stem cells actually wander into the damaged organ and settle there and help with the repair mechanisms. So that is one very, very key component we should not forget in this topic. So if you think about changes of the circulation as soon as you're cutting and clamping and cutting the cord, obviously the circulation stops, and then the oxygenation, which actually comes from the placenta, as long as the placenta is still connected to the mom, it will actually provide for the baby. And then the fetal shunt should close, and we can have a fluctuating circulation if the baby's circulating volume is not filled very well. And also there are changes in the capillary bed. I'm very interested in sort of microcirculation, and that gets dilated and the resistance decreases. So again, blood is sort of flowing into it, which then is being taken away from the other organs. So as babies are taking their first breaths and expand their lungs, there is a dramatic decrease in intrathoracic pressure, and that draws blood from the right ventricle into the lungs. And it's needed so that the lungs can start functioning to exchange the oxygen, to change the oxygen uptake. That in turn lowers the right ventricular pressure, and the foramen ovale, which is obviously open before birth, is starting to close. And then the blood return, of course, increases into the left atrium because there's more blood flowing through the lungs, and that's a reversed pressure gradient that helps also with the closure of the foramen ovale, so that the circulation can be established. And so as the pulmonary blood flow increases very quickly, the left ventricular output doubles within an hour. There have been some echocardiography studies looking at the stroke volume and cerebral blood flow, which are then increasing. And they calculated that before birth, if you look at the fetus, the combined stroke volume is about 450 mL per kilo per minute. And after birth, it rapidly increases to 800 milliliter per kilo per minute. So that's both ventricles combined. And that's for the numbers are for term babies. So that's a massive change. And as you can imagine, if you have more volume to help us with all these changes, then the heart can function much, much better. So in terms of blood volume for the baby, we calculate that normally we have about 100 to 120 mils per kilo in the whole circulation of combined placenta and baby. And we are aiming for it getting at least 85 to 90 mils per kilo into the baby during the delayed cord clamping. And that has been shown to be achieved by the colleagues who studied the circulating blood volume by using the biotim method. There were colleagues in Cardiff and Glasgow who have done some studies. And also even in 1960s, there was some study by Yao and Lind who measured that with radioactive markers, which of course you can't do these days anymore. I already mentioned that there's a lot of changes in the blood pressure, which we are experience and what we are aiming for. So the extreme prematurity babies are obviously starting very, very slowly, but then they have a very steep increase. And as they're going to full term, that, as the heart gets stronger, the prematures are a bit better. And then term babies start as a higher values. Small for gestation age babies might have lower values. So when you are looking at blood pressure measurements in babies, it's really important to consider what is the background of the baby, not just looking at sort of flat out numbers. It's always important to have the context as well. So when the early studies were done, looking at delayed cord clamping, where immediate cord clamping could be nicely shown. Here's one by Bacchus in 2016. That the mean blood pressure was increasing in the first 24 hours, and that the blood pressure values were higher for babies who were exposed to delayed cord clamping. And that was, in babies really with very, very immature babies of 22 to 27 weeks gestation. We looked at this as well. We did a study on comparing delayed cord clamping. At that time, it was still 30 seconds or milking of the cord And in both groups, blood pressure went up. There was a bit of a better blood pressure values in the milking group, but that was not massively significant. Then if you look at adaptation with the intact cord, so this is a study by Brouwer. They did a pilot study in 37 preterm infants, less than 35-week gestation, and they looked, were able to obtain values within the first 10 minutes of life. And you could see that the heart rate was slowly going up. So they left the cord intact until the heart rate was at least 100 breaths per heart rate, 100 beats per minute. And the first breaths were established, usually by 4 to 6 minutes. And they provide respiratory support if needed. They use a bespoke trolley. And there are lots of things you can see. The heart rate is really stable under these conditions. And what is really important to learn is about the saturations. So don't expect the baby to have a saturation of 101 minute of age. It does take time. And you don't need to panic about that, because if you think intrauterine, the oxygen saturation is about 45%. And babies have been very fine with that over the last how many weeks there were. So it's important to get to let the baby have their time to adapt to the extrauterine life and not to stress them out. Of course, that's very important, very difficult for us. So I think we have to teach ourselves, and as I said, keep calm and don't do any harm for that. So what is happening if the baby has got a circulatory problem? That can cause, there was a nice paper by Heike Rabe that can cause global tissue hypoxia. So in all the organs, because you have an imbalance between the systemic oxygen delivery. So even though the central saturation might be good, and the oxygen demand in the different organs. And that is, of course, influenced by lots of factors. One is poor myocardial contractility, which you can measure with your echocardiography. And then other factors like respiratory failure, patent ductus, anemia, sepsis, and asphyxia. So the treatment for this condition is still under investigation, but we should try and really balance it out as much as we can. So what are influencing factors to achieve a good balance or benefit of optimal cord management? We can make use of the uterine contractions. As this squeezes on the placenta, the baby is still pumping blood towards and blood comes back from the placenta. That has been shown in some Doppler studies, and you will not, there can be blood flow even though you cannot feel a pulsation from the cord. There will be still an exchange until the circulation stabilizes. Some studies have shown that gravity might have an influence to improve the flow from the placenta into the baby, but the people are now divided. The important thing to tell is to tell the obstetrician or midwife not to lift the baby up above the placenta. Here is the baby, especially in cesarean section, it's quite common, and then because that enhances blood flow back into the placenta. So baby drains into placenta, which we actually don't want. The question is when to start the stabilization with using a bit of respiratory support, because if you are doing it too vigorously, you might cause a vagotonus stimulation, which actually in a turn could cause a bradycardia in the baby, which you don't want, or they have a reactive apnea because they're sort of frightened about that. Just to in terms which I will talk in a minute, the iron stores are very much improved, and the need for blood transfusions is reduced, so that's very good. There's always a bit of a worry, do the babies get symptomatic polycythemia, but that has not been proven. Lots of studies have looked into that. There's jaundice will still occur and the need for phototherapy, but there was no increase there's no significant increase in need for phototherapy length, or an exchange transfusion has not been sort of reported. So as I mentioned already, how do you stabilize if you want to, start stabilization whilst the cord is still intact? So there are a couple of studies looking into this. This is one by Kateria, where he looked in preterm babies who were delivered by cesarean section, less than 32 weeks gestation. And there were two groups. One was just having delayed cord clamping and a little bit of tactile stimulation and wrapping the baby up. And the other one received some ventilation breaths after birth. And what he found actually is that within the first 60 seconds, 90% of all babies were breathing by themselves in both groups. So there was no difference. So again, as I've mentioned before, first do no harm. And we really promote now that we should let the baby breathe first and then give them some help if we think it's really, really needed. That was also confirmed by Michael Meyer, who did a study in very preterm infants doing optimal cord clamping time, less than 31 weeks gestation. And he looked also again into the likelihood of breathing in the first 15 seconds. So he made it even tighter. And of course, the likelihood is lower if you're in less than 26 or 27 weeks gestation, but it really goes up quite quickly in the older babies. So we need to also focus on these babies and how to best support them, and the difficulties to find out who needs extra support and who might start breathing themselves, because that helps them also filling the microcirculation in the alveoli, which then in turn helps with oxygenation in the blood. The colleagues in the Netherlands and in Australia have done some really nice studies looking at heart rate and oxygen saturation under stabilization with intact cord. They were able to do really frequent recording. And as you can see, the heart rate increases because, obviously with increased blood volume, the stroke volume has to go up and they have to pump it around. But what you can also see is that it actually stabilizes and that it goes down once the circulatory volume, optimal volume has been achieved. So again, the babies, doing the hard work themselves. And that's, I think, very reassuring. Again, they looked at the oxygen saturations. And as you can see, there's, of course, this a steep increase, but it does take time. So here's about 4 minutes here. Yeah, you see that when they're going above 80. So again, we let them, don't panic and let the baby breathe themselves. They have done a bigger study now where they looked at heart rate and oxygen saturations in babies having cesarean sections and or vaginal delivery. And as you can see, even by 10 minutes, so again, they have an increase in the heart rate, but then it stabilizes. So it really, and that is done in both in this babies with cesarean section and the babies who have a vaginal delivery. And here you can really see the saturation. I mentioned it starts about 45%. And then you have a steep increase up to 10 minutes above 80. And that's a lower margin here. So really, if we let the babies adapt by themselves, they do it, and it takes time. And the vaginal delivery has a similar curves. So for birth, for both babies, or both groups, I should say, it is possible to have the placental transfusion transfer in cesarean sections and in vaginal deliveries. We think that the cesarean section might take a bit longer, but because of once the baby starts breathing by themselves, as I mentioned before, the intrathoracic pressures, they sort of pull in the blood into the lungs, and we give them the chance. So how to convince the people? You have to do meta-analysis, and I'm part of the ICOM group led by Lene Seidler and others in Australia. And we they wrote to all the authors who have done published studies in this field, and we did sort of what is called a meta-analysis with individual patient data. So we all provided our individual patient data for this kind of analysis, and what it helps you, we could also do a more complex analysis. So we could compare different timings of the delayed cord clamping and with immediate cord clamping, and also with the milking and the different types. Unfortunately, we didn't have enough data for cord stabilization with the intact cord, but hopefully with the next round, we will be able to do that. So what we found, similar to what our other meta-analysis have shown, that there's a positive effect with a similar size of effect with regard to mortality if you provide delayed cord clamping. And there were some studies which even did 120 seconds, and that seems to be a bit stronger in that. So if you look just at mortality, if you look immediate cord clamping versus delayed cord clamping, it favors delayed cord clamping. Same, little bit less stronger for cord milking because there are less studies, and there's no difference between delayed cord clamping and milking. And as I mentioned, with the resuscitation, with cord tuck, we didn't have enough studies, but there's a trend toward favors in this method as well. So in summary, we do have the improved mortality, but I just want to remind everybody that the survivors will still develop the comorbidity of prematurity. So it does not, cure all ailments. And so far, we have not demonstrated any sort of risk in the meta-analysis. And what we're now thinking about that is really immediate cord clamping is a intervention which might cause harm and definitely reduce the chances for survival. So I encourage everybody to make plans for implementation, use an MDT approach, which I'll show you in a minute, and then audit your own practices. In line with that, the WHO has done a newborn essential care package where they recommend the 1 minute, and they do a little bit of stabilization and checking on the baby. So by the time you're doing all of that, 30 seconds are already over, and they recommend even clamping the cord after the pulsation stops. But I mentioned the recent studies have shown that you cannot always assess that very securely. Just to remind, why did we actually clamp the cord immediately, which is this is the intervention that was sort of invented or introduced in like 1950s, 60s, and when the obstetricians were worried about postpartum hemorrhage of the mother. And then it was introduced without any formal studies. So now there are studies showing that actually postpartum hemorrhage is not increased with delayed cord clamping. There are specific studies who have looked into that. So that is a no now, and that's why the WHO said in 2016 already that immediate cord clamping is contraindicated. I'm working on it to spread the word, like today in this things. The other thing I want really to mention is that please inform and involve the parents. So when we did a study together with Lilia Dewley on the resuscitator used in the UK, we did parent questionnaires, and parents told us that in that situation, when they were told about the delayed cord clamping, they felt that is something they could contribute to the baby's health in a situation where they're not in charge and not in control of the things. So and they wanted an altruistic attitude, that this were all parents in the UK, and saying, even if it doesn't help my baby, it will help, the next baby. So that's really listen to the parents. And as you probably know, we have the EFCNI, which is a stakeholder organization across Europe, which are now, they changed the name to GFCNI. And they have done, well, actually, Ola Andersen and myself, we have done together with colleagues from other countries, a sort of standard of cord management for term infants and for preterm infants, which you can take to your stakeholders and really promotes education for parents and for staff on how to enable the optimal cord management at term. I just want to remind everybody about the Brighton pathway for babies below 34 weeks gestation, where the antenatal optimization includes preparation for optimal cord management, and we have also recommended there to use 60 seconds of that. And there's a little sort of list on how we can improve. So we don't recommend the early cord clamping. Please develop your own unit guidance. There's some example on how to do it in the Brighton pathway. And please continue if already optimal cord management established. This is one example how we do it in Brighton. So we have so-called step cards for high-risk deliveries. And as you can see here, optimal cord clamping is management is mentioned here in the step card. So as we are, for example, preparing for cesarean section of a preterm babies, we make a plan together with the obstetricians and the midwives how this can be achieved. So that's really important. So we do think, the question is, why does it make a difference in regards to survival? So I personally think that that the stem cells play a very important part, even though we can't really prove it. And then the sustained circulation is really helping with improving the blood volume of the baby. And then therefore more interactions then can occur with all the organs kicking into sort of work and into improving the baby's condition after birth. So that's just 3 things to think about. So I just want to quickly mention the term infants, not to forget about them. So we recommend at least 3 minutes in them. And why is that? Because the babies we are concerned about are the ones with HIE. So they have a decreased blood flow to the brain after this sort of events. And if you do immediate cord clamping in them, they're really depleted about their blood volume. So if you can get the stem cells into these babies, then at least they have a chance to repair, and recover from the events, which quite often are before birth. So you can't really do anything about that. And again, there are some studies going on, how we could improve the outcome for babies with HIE. Just a quick run through of a model. How does it benefit the term babies? You might be aware of the studies by Ola Anderson, who did a lot of studies in term infants in Sweden, but also in Nepal, so in developing countries. They get about 25 to 35 mils per kilo extra placental blood. That leads to higher hemoglobin, because even at 3 months, because we don't take so much blood out of them. And then they still have better iron supplies and storage at 4 to 8 months. And some studies have done that, shown that at 1 year. And the most important thing is that that protects them in the first year of life from anemia, which is very important to reduce the risk for infections in these babies. And they've shown that there's a better neurodevelopmental outcome at 4 years of age, which I find really amazing. Even in a place like Sweden, which has good nutrition and everything, you can see a difference. So I'm still in awe about that, to be honest. We are just doing some other studies where they provide delivery, stabilization, and resuscitation after birth. We're just writing up the first papers on that. And again, they've used a lot of qualitative studies looking into staff attitudes, barriers, challenges, and also did extensive questionnaires to the parents as well to get their feedback and how to improve what we are doing. So this is a pathway for the WHO term babies. So they recommend to dry the baby, assess the baby, put them skin to skin, and then wait for 3 to 5 minutes before cutting the cord. and then initiate the breastfeeding within 1 hour of age, which you are hopefully all aware is very, very important for further breastfeeding success later in life. I just, because you are interested in circulation, a few words about if babies are having difficulty with the circulation. I'm part of the International Neonatal Consortium Haemodynamics Adaptation Group, and we are working on things together with EMA and FDA on standards which are needed for future drug development in circulation. So if anybody's interested, please join. You can find us on the internet. So we have done a publication on how to what would be the best standard of care if you don't have intra-arterial blood pressure measurements. So make sure that the cuff is appropriate for the size of the baby and it's appropriately applied, for example, in the middle of the upper arm. And so that will be used in future drug studies. Liam has already mentioned the neocirculation studies which we have done, and just a few messages from what we have learned so far. We looked into the standard, so that was developing an age-appropriate formulation of diobutamine. And as part of this, we looked at the standard on how do we actually provide the inotrope if the baby needs one to the baby. And what we learned from that is that it's important to have a standard infusion which goes near to the central venous catheter. And it's once you press the button on the infusion pump, it still can take up to 60 minutes before the first drop goes into the baby, because we have such a slow flow rate for these infusions. So that keep in mind if you next time you are prescribing inotropes. Liam has done a lot of studies on microcirculation and pulse wave extraction of cardiac data, and I leave it to him to give another lesson on that in another trace, but I want to advertise that a little bit if you haven't done that yet. We also looked into stability. As you know, we have to mix dopamine, diobutamine with infusion, like with glucose or normal saline. And we're the students looking into that, and we actually found quite an instability, sometimes after 24 hours and sometimes after 12 hours. As, quite often we observed that once you're changing the infusion of dopamine after 24 hours, for example, shortly before the blood pressure of the baby was going down, and then as the new infusion kicked in, you have a steep increase in blood pressure, which you don't actually want, because these fluctuation in blood pressure can cause intraventricular hemorrhage and under instability. So we established what should be the future inotrope application. We now change our infusions every 12 hours, not every 24 hours. Wait for 30 minutes, so it's really stable when you put it into the infusion pump, and wait for at least 30 to 60 minutes, depending on the size of the baby, before you titrate the dose in case you see any response of the baby. And we found that the best stability for dopamine would be in glucose 5%, diobutamine in normal saline, noradrenaline in glucose 5% and normal saline mixture. And you need to cover that one for light protection if the baby is under phototherapy. So this is in our guideline now, and you might be aware that currently the neonatal pharmacists in the UK, or at least here in the Southeast Coast, are producing a neonatal sort of guideline for prescriptions, and the results of this will go in there. So hopefully everybody in the UK can benefit from these results very soon. Right, with that, I think I've stuck to time. Thank everybody for attending the lecture, and these are all the stakeholders which we are working with, and I'll thank especially colleagues who have provided me with some illustrations. So I'm happy to take any questions. So I stop sharing. If I can stop share. Yeah.
Thank you, Prof. It's a fantastic presentation, and thank you for coming in. I would invite any questions from the floor and wait for any questions to come up. Now, there was something in the meantime I was actually hoping to ask. Well, I may already have a question. I've got a question from Rajan. Is there any contraindications at present for delayed cord clamping, like severe IUGR or reversal of flow in umbilical artery or in RH isoimmunization?
Yeah, so that would have been another talk. So there's still quite a number of worries, but most of them are myths. So the first important thing is that even if you have a baby with intrauterine growth retardation, they can also be hypovolemic. So they need their volume, they need their stem cells. They might have, I've got an interesting slide which I couldn't put in. There have been a study on discordant twins, where one baby is born normal, size normal, and the other one is smaller, and they have a higher resistance and elasticity in their arterial and venous umbilical cord vessels. So they're, which is why they're more prone to hypertension later in life. You might know that, and cardiac complications and so forth. But they still, after birth, they need to fill their lungs and they need to fill their organs. And don't worry, because if you're leaving the cord open, any blood which is too much, they send back to the placenta. There's a nice study from José Diaz-Rosello in Uruguay, where he put term or sort of near-term babies on a scale, which is sort of adapting. And it shows that initially the baby's birth rate goes up because more blood is transfused into the baby. And then it goes actually down a little bit, goes down, and then it balances out. So it's a bit like what I've shown with the heart rate. The babies, they take the blood they need, and the rest, sending back to placenta. Then there have been some studies on RH immunization incompatibility, and that actually shows that those babies are also hypovolemic, and they really need their stem cells and the red cells. So it has been shown that if you provide the cord clamping, that can delay. So first of all, you can avoid blood exchange transfusion because the initial hemoglobin is higher. They will still need blood transfusion later in life, and has no, because the hemolysis will still go on, and they need their phototherapy. But if you can avoid a blood exchange transfusion, which has lots and lots of risks, that is a huge benefit. So these kind of things, and then there are other myths like babies with cardiac congenital abnormalities and so forth. So all of them, they need blood volume, and there are now studies going on with babies who have diaphragmatic hernia, for example, pulmonary hypertension, and these kind of things. So was there another condition? I can't remember now what he was asking.
Well, he mentioned primarily, RH isoimmunization.
Yeah. So definitely those babies will definitely
benefit.
Yeah.
Okay, I'll wait for other questions. In the meantime, I wanted to ask you something while the questions come through. Now, you talked about delayed cord clamping, which is obviously the generally recommended placental transfusion strategy. Now, there was a slide where you actually showed that milking of the cord can actually show slightly higher blood pressures. Now, I believe, or the way I understand it, it's actually not practiced. And the reason for that is that particularly in the preterm babies, there may be risk of IVH and things. But what about in term babies? If you have a situation where the baby potentially have lost blood, and maybe because of a sudden abruptio placenta or anything, do you recommend milking of the cord, or do you still stick to the norms of just delayed cord clamping in near-term babies?
Yeah, so in those babies, we do use it as a backup method, because quite often it's not really practical to do the delayed cord clamping, because there's something wrong with the mom as well. And we are now discussing, what I've recommended here in Brighton is to, or other colleagues have done it as well. What you can do is you hold up the placenta above the baby's level so that you have the drainage, and then you can gently milk the cord towards the baby. So, the thing is, with the milking, it's guaranteed transfer of blood. And you can see, you know, it's the umbilical cord refills. So it's really, so you have to have an intact cord to get the blood in. The problem, it's not a problem, but what people are discussing is that because it's not the sort of gentle transmission, it's a bit artificial sort of thing. So that's why the trend in the discussion is in the moment to try to be as sort of physiological, what we call physiological as possible. Which of course in preterm is not quite, you know, what's physiological in an extreme preterm infant, really nothing. So anything which we do is artificial sort of thing. But definitely, I personally think that the milking of cord, especially in term babies, will be one method of you know, providing them with the blood they really need.
Okay, thank you. Any other questions from anybody?
Thanks so much, Heike, for this excellent presentation and overview on neonatal hemodynamics. And I have a question from a hospital where it's mostly adults. And in our hospital, we do cord blood donation. And there is a debate because we want to apply recommendation even for neoterm and term babies. And we were told, well, you cannot do both cord delayed cord clamping and cord blood donation. What is there are a few studies on that. What are your opinions? Can we do both of them? Can we do 30-second cord clamping, delayed cord clamping and blood donation? So what are your opinions?
Well, so this is a really interesting question. And for me, it has also ethical aspects. So if you only do 30 seconds of delayed cord clamping time, you are asking the baby to do blood donation as a donor. And if you think about the law, blood donation in children under 18 is not permitted in the UK. So if you look at from the side of the baby, I think that's already a sort of very ethical, you know, questionable approach. So my opinion is, so first, do no harm, yeah. And the benefit for the baby is that the placental blood belongs to them. It's not the mother's blood, it's the placental blood, and it has to be in the baby. So the minimum should be 1 minute and not lifting the baby up above the mother, which in some hospitals are done. Because you think about, and in term babies do the 3 minutes, because that will benefit the babies in 4 years' time. Yeah. You can still harvest the remaining blood from the placenta. That has been done. Of course, the volume is less, but in the future, first of all, the claiming of these companies is that, you know, you can do all sorts of things with this blood. Quite often, it's not even if you use a full placenta, it will not be enough for an adult, for example. And we do not actually know whether in 20 years' time you can do anything with that, you know, healing either the baby or somebody else. So I think what we have to do, we have to think, as a neonatologist, you have to think about the interest of the baby first. That's an ethical thing also for us to consider, and really also explain it to what should really be done to explain to the parents that their baby will be a blood donor. And, you know, and what does it mean in 4 years' time if you do immediate cord clamping instead of you doing the lovely 3 minutes, and they, you know, when they go to school, they're better. So these kind of things one has to consider. So I would say do the delayed cord clamping first, then you can clamp the cord. Of course, it's a bit more effort, but we did some blood harvest study in Münster where I worked before, and you still can get blood out of the placenta. You just insert a collection needle near to the placenta and do a little bit like a tapping on it. So it's possible to get blood out of the placenta. And some people have done that as part of looking into how much residual blood is in the placenta if you do different timings for the cord clamping, to see, you know, and how to get some idea of, you know, what is the circulating blood volume for the different gestations. So it is possible, of course, in more effort.
Thank you.
Right. Thank you very much. I've got another question from one of the attendees, Rajan. There are 2 parts to the question. The first question is there any standardized technique described regarding cord milking, like how much forcefully you milk, or how much length of the cord you milk? That is the first question. And the second question, I think you've already alluded to it before. Another question is regarding gravity, whether while doing the delayed cord clamping, whether the baby should be held at a lower level than the placenta. So 2 questions.
Yeah, so I actually did if you look at my original paper of the delayed cord clamping, where the 4 times milking of the cord, I did describe the 4 times milking and how did I get to it. So I based it on our experience in Münster, where we did the cord collection studies, and where we actually did a separate collection from the cord only and the placenta. So I knew how much blood will be roughly in the whole cord. I also assumed that if you do the milking of the cord, you only have about access to half of the cord length, because if you, for example, vaginal delivery, you know, some of the cord is inside the baby. So I assumed that, you know, only a sort of length of maybe 20 centimeters, depending on, you know, how long is the cord. And then I assumed that that only contains half of the volume which we measured in the cord, so that was 10 ml, and I wanted to have about 40 mils of blood transferred to the baby. That's why I chose the 4 times milking. So the important thing is when you do the milking, hold the cord gently with one hand and don't suppress it, and then just gently sort of squeeze it out, and it doesn't need to be a lot of force, because you can see how the cord will empty. And then you can also see how the cord will sort of reload with blood afterwards. So it doesn't need to be massive, you know, a massive force. The other thing to consider is that there were some animal studies in lambs where when they did the milking, they did a different technique. They clamped the cord at the side of the placenta and then milked towards the baby. So that is in order so that they get more sort of a change in, you know, blood flow and so forth, and they could see some, of course, then you see a peak in blood perfusion into various vessels. So if you keep everything open, the baby can also send something back if it's too much for them. That's always the idea of keeping the cord intact and keep it open. And the other question was about
regarding the gravity, the role of gravity while doing the delayed cord clamping. Yeah, we
do it. There are some studies which shown if you have it on the level of the placenta, that is also possible to enhance the placenta transfusion. But I think that's more in term babies. So I think the general recommendation is to use the gravity if you can. But of course, in a cesarean section, that's not possible. So we just put the baby on the mother's side. And that's why the effect of the transfusion takes a little bit longer if you have a cesarean section.
Okay, thank you.
Liam wants to say something.
Well, thanks, Heike. I just wanted to quickly ask about the studies, and I presume that quite a lot of these studies are done in singletons. And I just wanted to ask about can some of this research and the findings be applicable to twins of all different types, you know, DCD, AMC, MA, etc.?
Yes. Yes. So there are studies now just looking into twins, and they show that both twins can benefit, and they both get the placental transfusion. There's not that much connection on the placental level that much. The people are a bit divided about if you have monochorionotic twins, and some recommend, some don't. We do all. And we also do triplets. I mean, not me, I'm an obstetrician, but, you know, it's possible to everybody, and especially the last triplet, yeah, they need their blood. So, you know, don't rush. Of course, it's a bit more tricky because you have to deliver this one and the other one and so forth. So it's a bit of logistical feature, especially in sections and so forth. You know, there's only so much space you have on the tummy of the mother, but it's possible for everybody. Yeah.
Thanks, Heike.
Thank you. I don't have any questions from anybody else. So I'll try and ask you one other thing that I just wondered. So in a term baby, as you were saying, that mostly the recommendations would be up to anything between 3 to 5 minutes. Now, we are talking about a cord which is outside in the air, and there would be some degree of spasm of the vessels within the cord. Now, that is primarily going to be in the arteries, I would think, rather than in the veins. So would that have any effect in the blood flowing if we are delaying it for a good few minutes because of the spasm? Or is it just the venous blood which basically flows through anyway because they don't go into spasm, if that makes sense?
Yeah, as I mentioned, quite often the pulsation stops, but the blood flow is still going. It's just slower. And remember, the baby takes as much as they want, and they only send blood back if they don't need it anymore. So there's no contraindication. What I would caution about, because there were some sort of case reports, if you leave the cord connected for too long, you can also have the adverse effect that even after 20 minutes, if the vessels are still open or opening up again, that actually the baby bleeds into the mother. You can have that as well. So that's why we're saying 3 to 5 minutes, and basically to be on the safe side, because you don't want bleeding the other way.
Right. Okay. Thank you. Anybody? Any further questions?
Stunned silence.
Well, hopefully I've answered all the questions people might have had.
Oh, yes, you did.
Thank you, Heike. So thanks very much again, Heike, especially for taking your time out whilst you're away in Toronto as well to
Oh, it was a pleasure.
to present to us. Now, that was a fascinating talk, and yeah, just wanted to say thank you very much for that. And again, to the rest of the group, that the next talk will be back on the 19th of September here again at I think it might be a slightly different time of 3 o'clock, but look out for the advertisement which will go on the WhatsApp group. But it just leaves me to say thank you very much to Professor Heike Rabe again for her time today, and for all of you who've joined. And we'll see you again soon in the next next installment of the NeoFOCUS education program. All right.
Thank you for watching. If you enjoyed this, please check out the other webinars on our channel.